Hello, my name is Stefan Kertes from University of Alabama at Birmingham. I am going to be recording, or rather re-recording, comments that I made on October 14th at the Margolis FDA convening session to reconsider mandatory opioid prescriber education through a risk evaluation and mitigation strategy, or REMS, in an evolving crisis. This was a two-day virtual public meeting that took place on the 13th and 14th. I was asked to give about 5 minutes of comments, and some people were interested in the recording, so that's what I'm offering. Let me say straight up that speaking here, I'm sharing my own views and not those of my federal employer. I want everyone to know I happily serve on a volunteer scientific board for the National Pain Advocacy Center, which is a nonprofit. In terms of disclosures, I own shares in two biomedical equipment companies, Zimmer and Thermo Fisher, and I owned some CVS Caremark stock briefly in 2020, but I had it sold once I learned that my broker had purchased it. While you're absorbing this very blunt title, let me make one thing known. I really do support education in pain, on opioids, on addiction, on related issues, and I like to participate in that education. What I want to speak about today is what the model of a national mandatory REMS is, and what that model can do and what it can't do. And the easiest way to explore that is to talk about a prototype of an effective and successful REMS program. And that's the FDA-mandated REMS program for isotretinoin, which is commonly sold as Accutane. I think even when this is a treatment for acne, and even when I got that medicine briefly, I had to go through this program in order to assure that no pregnant person would be exposed to it. So the model is very straightforward. There's a specific disease condition. We learn about it in medical school. There's a specific treatment for the disease, which works. There is a specific risk attached to the drug, a discrete drug exposure risk, and there's a REMS to mitigate that. So let's try to map that onto opioids and pain, and I'm really thinking even more about the template of chronic pain here. This is the model, but it doesn't fit as well, and problem one is that pain, and particularly chronic pain, is not exactly a single disease like cystic acne. It's wrapped in the elements of the psychosocial model, which are shown in green, and in the patient's context, which includes whether they have addiction or dependence, whether that even non-addiction, trauma from the healthcare system, which is very common for people with chronic pain, and disability. And it's a real problem that this web of factors that should influence our evaluation and care plan are not taught in health profession schools. Problem two is that the prescription opioid is not exactly the treatment. I understand there's disputes about whether they are as effective as other treatments or not, but the choice really sits in this network of other opportunities and other ways to treat chronic pain that we're trying to choose among, depending on the patient's situation and those factors on the left. Problem three is that the risk for the treatment is partly pharmacologic, but it's such data as we have on overdose, at least, especially VA data, suggests that the risk is heavily influenced by many other factors attached to the patient. These are factors that are going to influence the volatility of the patient's pain, their relationship to the clinic, and they include things like prior mental health diagnoses, pre-existing medical diagnoses, co-prescribed medications, whether the individual has been admitted to the hospital for substance use disorder or for detoxification. And those are really very important factors in terms of the risk, at least as important, in many ways more important than the prescribed dose, at least according to VA data. Finally, the prescriber is going to make a decision that's bracketed by an array of social influences. I used orange caution cone color here to bracket them. They include our collective reckoning with an overdose crisis to which we as a profession contributed, many other factors, including scientific disputes on what opioids can and cannot deliver in terms of pain relief, and an issue that matters a lot to me, which is that while there's a lot of factors influencing whether we write that prescription or continuant, there are no formal safety protections or ethical accountability factors for those patients who we cut off, which actually matters a lot. And the FDA itself has commented on this issue. For that reason, I just don't know if a REMS expansion could even mitigate given this model of pain. Of course, reducing of opioid prescribing has happened. This graph really is focused on milligrams per capita rather than prescriptions per capita. And I realize there's a lot of room for debate about the change in the overdose curve. The overdoses have gone up. The orange line is those that are related to synthetic drugs like illicit fentanyl. And I think there's debate as to whether the restriction in prescribing in any way contributed to that orange line going up. I'm not here to adjudicate that, but there was one goal that reducing prescribing was supposed to achieve, and I think that did happen, and I'm showing it here. What you see here is the Monitoring the Future survey data, which is federally collected or federally funded. Past year misuse of opioids, Vicodin being the green line, narcotics other than heroin, which is a broader category, being the orange line, for young adults. And the reason we focus on them is those are the key years for new onset addiction risk. And people have often said what we need to see is a reduction in prescribing to reduce the rate of exposure to these drugs so that fewer people would develop heroin addiction in the future. And what the graph shows is that the percentage of young adults who have had exposure to these drugs or report using in a very appropriate survey is now at a record low. In fact, that orange line goes all the way back to 1988. The percentage of young adults reporting exposure to these drugs has never been lower, and I'm just not sure it can go any lower. So with that in mind, let's turn to conclusions. The context we are in right now is an enduring prescription reduction, and I do think it reduced young adult misuse of these pills. Today's reductions are highly incentivized, they're often abrupt, and they're often unsafe, at least for some patients. And patients with chronic pain often do wind up without someone to take care of them. I believe medical schools should train in pain, disability, addiction, rehabilitation. I should say all health profession schools. And I think it's a shame that they're not required to as a condition of their own credentialing. However, given this problem as it's set out, mandatory REMS doesn't really fit the problem, and I do worry it may incentivize abandonment. Thank you for your attention. If you're interested in other presentations of my ideas, there's a reference to an article from Addiction and a TEDx talk. Thank you so much.